This lecture describes the pathophysiology and management of patients with select inflammatory cardiac problems. Conceptually, these problems can adversely affect perfusion. Inflammatory, infectious, and structural problems result in impaired cardiac output, which leads to decreased tissue perfusion and impaired gas exchange. The patient ability. The nurse plays a key role in providing the patients with the education needed to manage these problems and their effects. This is figure 36.1 from your textbook. It shows the layers of the heart muscle and the pericardium. The section of the heart wall shows the fibrous pericardium, the parietal and visceral layers of the serous pericardium, the parietal and visceral layers of the serous pericardium with the pericardial sac between them, the myocardium, and the endocardium. Infective endocarditis, or IE, is a disease of the endocardial layer of the heart. The endocardium is the innermost layer of the heart and the heart valves. IE most often dates around 40,000 to 50,000 new cases of IE are noted every year. The 1-year mortality for IE has not changed in the last 20 years. We often classify IE based on the cause, example, IV drug abuse or infective endocarditis or fungal endocarditis, or the site involved or fungal endocarditis, or the site involved, the prosthetic valve endocarditis, something like that. In the past, we've described IE as subacute or acute. The subacute form affects those with pre-existing valve disease over a period of months. In contrast, the acute form affects those with healthy valves, and IE occurs when blood flow allows organisms to contact and infect previously damaged heart valves or other endothelial surfaces. About 30% of the cases are caused by Staphylococcus aureus. Other bacterial causes are found. These organisms make biofilms, which protect the organisms from immune defenses and make antimicrobials less effective. There are lots of risk factors to develop endocarditis. We've already mentioned valve disease. Some of the others include cardiomyopathy, congenital heart disease, heart lesions like ventral septal defect, Marfan syndrome, a pacemaker, prior infective endocarditis, prosthetic heart valves, rheumatic heart disease, hospital-acquired bacteremia, IV drug use, and intravascular devices like central venous can be a risk factor. IE typically develops in 3 stages: bacteremia, adhesion, and vegetation. Vegetations, the primary lesions of IE, consist of fibrin, leukocytes, platelets, and microbes that stick to the valve surface or the endocardium. The loss of parts of these fragile vegetations into the circulation results in emboli. About 30% of persons with IE develop embolism. This occurs when the left side vegetation moves to the various organs such as the brain, the kidneys, or the spleen, and to the extremities, causing limb infarctions. Right-sided heart lesions move to the lungs, resulting in pulmonary. Already talked about regarding the pathogenesis of infective endocarditis. So what do we see when a patient has infective endocarditis? The manifestations of endocarditis are nonspecific and can involve multiple organ systems. Most patients have a fever. Fever may be low grade or may be absent in older adults and those who are immunocompromised. Symptoms include chills, weakness, malaise, fatigue, and anorexia. Patients may have arthralgias or myalgias or back pain or abdominal discomfort. They may have weight loss, headache, and even clubbing of the fingers in the subacute forms. Vascular signs include splinter hemorrhages, which are black longitudinal streaks in the nail bed. Petechiae from microembolization of vegetative lesions can occur on the conjunctiva, lips, buccal mucosa, and palate and over the ankles, feet, antecubital, and popliteal areas. Osler's nodes, which are painful, tender red or purple pin-sized lesions, are found on the fingertips and on the toes. Janeway's lesions, which are flat, painless, small red spots, may be seen on the fingertips, palms, soles of the feet, or toes. Eye examination may show hemorrhagic retinal lesions called Roth spots. Most patients have a new or worsening systolic murmur, but murmurs are usually absent in tricuspid IE because right-sided heart sounds are too low to be heard. Heart failure is common. It occurs in 80% of patients with aortic valve IE and 50% of those with mitral valve IE. Septic embolism is a potential complication from IE. Embolytic events occur in more than half of the patient. The central nervous system is the most often affected organ system, followed by the extremities, the spleen, and the kidneys. Health history is important when assessing IE. Ask the patients if they've had any recent, within the past 3 to 6 months, dental, urological, surgical, or gynecological procedures, including obstetrical delivery. No surgical or gynecological procedures, including obstetrical delivery. Note any history of IVDA, heart disease, recent heart catheterization, heart surgery, intravascular device placement, renal disease, or infections. 3 blood cultures drawn over a period of an hour from 3 different sites will be positive in most patients with IE. Culture negative IE is associated with antibiotic usage within the past 2 weeks or results from a pathogen not easily detected by standard cultures. The erythrocyte sedimentation rate, or the ESR, and the C-reactive protein, the CRP levels, may be in endocardiography can show vegetations. Guidelines for the diagnosis of IE are based on the Duke criteria. The patient must have 2 major criteria and 1 minor criteria, or 1 major and 3 minor, or 5 minor criteria. Major criteria include positive blood cultures, typical organisms for IE from 2 separate blood cultures, evidence of endocardial involvement, and new valvular vegetation. Minor criteria include predisposing heart conditions or IV drug use, vascular phenomena, immunological phenomena, microbiological evidence, or echo. Major criteria. A chest x-ray may show cardiomegaly, which is an enlarged heart. An electrocardiogram, or an ECG, may show first or second degree atrioventricular or AV block because the heart valves lie close to the conductive tissue, especially at the AV nodes. There are certain conditions and situations that require people with the following heart conditions should receive prophylactic antibiotics when they have certain conditions or procedures. Prosthetic heart valves or prosthetic material used to repair a heart valve, history of infectious endocarditis, congenital heart disease, including unrepaired cyanotic heart disease, repaired cyanotic heart disease, repaired congenital heart defect with prosthetic material or device for 6 months after the procedure, repaired congenital heart disease with residual defects at the site of or next to the site of the prosthetic patch or prosthetic device. And lastly, heart transplant recipients who develop heart valve disease. Following conditions or procedures, they need prophylactic antibiotics. Oral, such as dental manipulation involving the gums or roots of the teeth, or dental manipulation involving puncture of the oral mucosa. Respiratory, such as respiratory tract incisions, example would be a biopsy, or a tonsillectomy or adenoidectomy. And surgical procedures that involve infected skin, skin structures, and musculoskeletal tissue. Accurate identification of the causative organism is the key to successful treatment of IE. Long-term treatment is needed to kill dormant bacteria within the valvular vegetations. Complete removal of the antibiotic therapy is based on blood cultures. The effectiveness of the therapy is assessed with subsequent blood cultures. Cultures that stay positive indicate an inadequate or inappropriate antibiotic, an aortic root or myocardial abscess, or the wrong diagnosis. It is the reason to obtain 2 sets of blood cultures every 24 to 48 hours until the infection. Is cleared. After completion of the antibiotics, follow-up echocardiograms and inflammatory markers are done at 1, 3, 6, and 12 months. Fungal infective endocarditis and pulmonic valve endocarditis respond poorly to antibiotic therapy alone. Early valve replacement followed by prolonged, about 6 weeks or more, antibiotics is needed in these situations. Valve replacement surgery, which we're going to talk about later, is done in 50 to 60% of cases of infective endocarditis to prevent embolization or for uncontrolled infection. Fever that persists after treatment's been started is managed with aspirin, acetaminophen fluids, and rest. Complete bed rest is usually not needed unless the temperature stays elevated or there are signs of heart failure. Infective endocarditis with heart failure responds poorly to drug therapy and valve replacement, so it can be life-threatening. As we talk about nursing care, I want you to refer back to a table in your book, 36.3. Talks about the subjective and objective data to obtain from the patient with infective endocarditis. Assess vital signs together with heart sounds to detect a murmur or sounds like an S3. Arthralgia, which is joint pain, and myalgias are common. Assess the patient for joint tenderness, decreased range of motion, and muscle tenderness. Examine the patient for petechiae, splinter hemorrhages, and Osler's nodes. Complete a general systems assessment to determine any hemodynamic or embolytic complications. Forget about Janeway's lesions on the fingertips, palms, soles of the feet and toes, petechiae of the skin, mucous membranes and conjunctiva, or purpura, peripheral edema, or fingers clubbing. Respiratorily, you may see tachypnea or hear crackles. Cardiovascularly, you may have dysrhythmias, tachycardia, again, new murmurs. Diagnostic findings might be leukocytosis, anemia, elevated ESR, elevated CRP, and cardiac biomarkers. Positive blood cultures, hematuria, and other lab tests. Echocardiograms show chamber enlargement, valvular dysfunction, and vegetations. Chest x-rays show cardiomegaly and pulmonary infiltrates. Chest x-rays show cardiomegaly and pulmonary infiltrates. The ECG can show ischemia or conduction deficits. Signs of systemic embolization or pulmonary embolism can be seen. In this slide, we have our nursing diagnosis and some of the possible goals we might develop. Nursing care includes health promotion and teaching. We want to teach. Nursing care includes health promotion and teaching. We want to teach the patient at high risk for IE, which comes from our tables 36.1 and 36.2, how to reduce the incident and reduce the occurrence of IE. Tell the patient to avoid people with infections, especially upper respiratory tract infections, and to report cold, flu. Stress the importance of avoiding excessive fatigue, planning rest periods, and using good oral hygiene and scheduling regular dental visits. Tell the patient to inform the healthcare providers scheduling invasive procedures about the history of infective endocarditis, as prophylactic antibiotic therapy may be needed. Refer the patient with a history of IVDA to drug rehab. A patient with infective endocarditis have many problems that need nursing management. Infective endocarditis generally requires treatment with antibiotics for 4 to 6 weeks. After initial treatment in the hospital, the patient may continue treatment at home if hemodynamically stable and adherent. Assess the home setting for adequate to receive outpatient antibiotic need vigilant home nursing care. Assessment findings are often nonspecific, so tell the patient and the caregiver about the importance of monitoring body temperature. Persistent temperature elevations may mean that the antibiotic is ineffective. Patients are at risk for life-threatening complications such as stroke, pulmonary edema, and heart failure. Teach the patient and the caregiver to recognize the signs and symptoms of these complications, such as change in mental status, dyspnea, chest pain, or unexplained weight gain. The patient needs adequate periods of physical and emotional rest. Bed rest may be needed when the patient has a fever or complications. Otherwise, the patient may perform moderate activity. To prevent problems related to decreased mobility, have the patient wear elastic compression stockings, perform range of motion exercises, and deep breathe and cough every 2 hours. The patient may have anxiety and fear. You must recognize this and begin strategies to help the patient cope with the illness. Monitor lab data, including blood cultures, to determine antibiotic effectiveness. Assess IV lines for patency and signs of complications. Give antibiotics as prescribed and monitor the patient for any adverse drug reactions. Teach the patient and the caregiver the nature of the disease and how to reduce the risk of reinfection. Explain the relationship to stay healthy. Teach the patient about the symptoms to report that may indicate another infection. Finally, explain the importance of prophylactic antibiotic therapy before certain invasive procedures. Finally, our evaluation focuses around maintaining adequate tissue and organ perfusion, normal body temperature, and to increase physical and emotional. Next inflammatory heart condition is pericarditis. Pericarditis is a condition caused by inflammation of the pericardial sac, which is called the pericardium, often with fluid accumulation. The pericardium is composed of the inner serous membrane, the visceral pericardium, and the outer fibrinous or parietal layer. The pericardial space between these two layers normally holds 10 to 15 milliliters of serous fluid. The pericardium anchors the heart, provides lubrication to decrease friction between heart contractions, and helps to prevent excessive dilation of the heart during diastole. Causes of pericarditis include infectious, non-infectious, and hypertension. Infectious might be bacterial, fungal, viral, or others like toxoplasmosis or Lyme's disease. Non-infectious could include an acute MI, cancer, dissecting aortic aneurysm, myxedema, radiation, or renal failure, or even trauma. Hypersensitivity or autoimmunes would be something like Dressler syndrome. It might also be drug reactions or a post pericardiotomy syndrome or rheumatic fever or rheumatological diseases. There are three types of pericarditis: acute, subacute, and chronic. Acute pericarditis develops rapidly. Causing the pericardial sac to become inflamed and leak fluid. We call that a pericardial effusion. The characteristic pathological finding in acute pericarditis is inflammation. There's an influx of neutrophils, increased pericardial vascularity, and eventually the fibrin deposits on the epicardium. Subacute pericarditis occurs weeks prior to pericarditis, lasting more than 6 months as chronic. Myocardial infarction causes 5 to 8% of acute pericarditis cases. Post-MI syndrome or Dressler syndrome pericarditis can occur 4 to 6 weeks after a transmural MI. This syndrome is more common after a large anterior infarct. Viral pericarditis is often seen after respiratory or GI illness. This is a picture of the fibrin deposits on the epicardium. Clinical symptoms include progressive, severe, sharp chest pain. The pain is generally worse with deep inspiration and when forward relieves the pain. The pain may radiate to the neck, arms, or left shoulder, making it hard to distinguish from angina. One distinction is that the pain from pericarditis can be referred to the trapezius muscle, which is the shoulder above the back. If the patient complains of dyspnea, it's related to the patient's breathing in rapid shallow breaths to avoid chest pain. Fever and anxiety may worsen the dyspnea. The hallmark finding in acute pericarditis is the pericardial friction rub. The rub is a scratchy, grating, high-pitched sound believed to result from the friction between the roughened pericardial and epicardial, the lower left sternal border of the chest, with the patient leaning forward. Since it's hard to tell a pericardial friction rub from a pleural friction rub, ask the patient to hold their breath. If you still hear the rub, it's cardiac. Pericardial friction rubs may be hard to identify because they are often intermittent. The major complications of pericarditis tamponade. It can occur rapidly or slowly, and large effusions can compress structures nearby. Pulmonary tissue compression can cause cough, dyspnea, and tachypnea. Phrenic nerve compression can cause hiccups. Compression of the laryngeal nerve may result in hoarseness. Heart sounds are generally distant and muffled. Blood pressure is usually maintained. Cardiac tamponade develops as the pericardial effusion volume increases and compresses the heart. The speed of the fluid accumulation affects the severity of the clinical signs. Cardiac tamponade can occur acutely, such as the rupture of the heart, cancer. The patient with the cardiac tamponade may report chest pain and is often confused, anxious, and restless. As the compression of the heart increases, there is decreased cardiac output, muffled heart sounds, narrowed pulse pressure, tachypnea, and tachycardia. Neck veins are markedly distended because of the increased jugular venous pressure. Pulsus paradoxus, if present, is a large decrease in systolic blood pressure during inspiration. In a patient with a slow onset cardiac tamponade, dyspnea may be the only manifestation. Chest X-ray findings are generally normal, but a large as cardiomegaly. The ECG is useful in diagnosing acute pericarditis, with changes noted in 90% of the cases. The most sensitive ECG changes include diffuse or widespread ST segment elevation. This reflects the abnormal repolarization from the pericardial inflammation. These changes are different from ST change pericardial inflammation. These changes are different from ST changes seen in the MI. In myocardial ischemia, there is usually localized ST segment changes. In acute pericarditis, serial ECGs do not show evolving changes such as those with an MI. An echocardiogram can determine the presence of a pericardial effusion, or a color imaging and color M mode can assess diastolic function and diagnose constrictive pericarditis. A CT scan and an MRI can visualize the pericardium and the pericardial space. As previously mentioned, chest x-ray may look normal or a pericardial effusion may look like cardiomegaly. Common laboratory findings include cardiomegaly. Common laboratory findings include leukocytosis with increased CRP and ESR. Troponin levels may increase in patients with ST segment elevation and acute pericarditis, which would indicate concurrent heart damage. Fluid obtained during pericardiocentesis or tissue from a pericardial biopsy may be studied to determine pericarditis. Management is aimed at identifying and treating the underlying problem and the symptoms. Antibiotics treat bacterial meningitis, and nonsteroidal anti-inflammatory drugs, or NSAIDs, control the pain and the inflammation. Corticosteroids are used for patients with pericarditis from systemic lupus erythematosus, patients already taking corticosteroids for autoimmune conditions, or patients who do not respond to NSAIDs. They are used cautiously because of their many side effects. Colchicine, an anti-inflammatory drug used for gout, may help patients with recurrent pericarditis. Pericardiocentesis is usually done for hemodynamic support for the patient before the procedure, may include giving volume expanders and ionotropic agents and stopping any anticoagulants. The procedure is done rapidly and safely using a percutaneous approach guided by echocardiography. A needle is inserted into the pericardial space to remove fluid for analysis. Heart pressure. Complications include dysrhythmias, further cardiac tamponade, pneumomediastinum, pneumothorax, myocardial laceration, and coronary artery laceration. A pericardial window is a surgical procedure for diagnostic or drainage of excess fluid. Cutting a window or part of the pericardium allows the fluid to drain continuously into the peritoneum or the chest. Nursing assessment for pericarditis should focus on trying to find the causative agent and on the pain. Assess the pain to distinguish it from angina from myocardial ischemia. The pain from pericarditis is usually found on the pericardium or left trapezius region and has a sharp quality that increases with inspiration. Pain is often relieved when the patient sits up or leans forward and is worse when lying flat. Objective data include evaluating patients' fever, looking at their respiratory rate and the work of breathing, and evaluating the patient's anxiety level. Nursing diagnoses and plannings focus on impaired cardiac function, activity tolerance, with the goal of achieving and maintaining normal baseline functions, managing pain, and adhering to the treatment regimen. As previously mentioned, acute care is going to focus around pain management. Pain relief measures include keeping the patient on bed rest with the head of the bed raised 45 degrees and providing an over-the-bed table for support. Anti-inflammatory drugs can help control the pain. Give these drugs with food or milk. Tell the patient to avoid alcohol because of the risk of GI bleeding. Other drugs such as a proton pump inhibitor can reduce stomach acid. Provide simple, complete explanations of procedures and possible causes of pain to help reduce anxiety. These explanations are particularly important for the patient who is undergoing testing and for the patient who has previously had angina or an MI. The patient with acute pericarditis is at risk for cardiac tamponade and decreased cardiac output. Monitor for manifestations of tamponade and prepare for possible pericardiocentesis. Evaluation of outcomes are similar to those with the patient with infective endocarditis. In moving to our next inflammatory disease, we're going to talk about myocarditis. Myocarditis is focal or diffuse inflammation of the myocardium. Causes include viruses, bacteria, fungi, radiation therapy, pharmacological and chemical factors. Kawasaki's A and B viruses are the most common causative agent. Autoimmune disorders have been linked with the development of myocarditis. It may also be idiopathic, which means we have no idea what the cause is. The features of myocarditis vary from a benign course without any overt symptoms to progressive heart failure, dysrhythmias, or sudden cardiac death. Fever, fatigue, malaise, laryngitis, dyspnea, lymphadenopathy, and nausea and vomiting are early manifestations of the viral illness. Early cardiac signs appear 7 to 10 days after viral infections because pericarditis often accompanies myocarditis. These include pleuritic chest pain with a pericardial friction rub and an effusion. Late cardiac signs relate to the development of heart failure and include an S3 heart sound, crackles, JVD, syncope, peripheral edema, and angina. The EKG changes with myocarditis are often nonspecific, but they reflect associated pericardial involvement, such as diffuse ST. They may include mild to moderate leukocytes and atypical lymphocytes, elevated viral titers, and increased ESR, CRP levels, and the levels of cardiac biomarkers such as troponin. The virus is generally present in the tissue and the pericardial fluid samples only during the first 8 to 10 days of the illness. Endomyocardial biopsy provides histological confirmation of myocarditis. A biopsy is most diagnostic during the first 6 weeks of the acute illness when lymphocytic infiltration and myocyte damage are present. Nuclear scans and MRI are used to assess heart function. Treatment consists of managing the symptoms. Angiotensin-converting enzymes, or ACE inhibitors, and beta-adrenergic receptor blockers, or beta blockers, are used if the heart is enlarged or to treat heart failure. Diuretics reduce fluid volume and preload. If the patient is not hypotensive, diuretics reduce fluid volume and preload. If the patient is not hypotensive, IV drugs such as nitroprusside and melrinone reduce afterload and improve cardiac output by decreasing systemic vascular resistance. Digoxin improves cardiac contractility and reduces heart rate. It's used cautiously in patients with myocarditis because of increased sensitivity to dysrhythmias and the potential toxicity. Anticoagulation reduces the risk of clot formation from blood stasis in patients with low ejection fractions. Myocarditis with an autoimmune basis is treated with immunosuppressives. These drugs reduce drug inflammation and damage. However, the use of these drugs for the treatment of myocarditis is controversial because they may lead to recurrence. In some instances, antivirals may be used as an adjunct therapy to treat myocarditis. General supportive measures include oxygen therapy, bed rest, and restricted activity. In cases of severe vascular assist devices may be needed. Focus your interventions on improving cardiac output and managing the signs and symptoms of heart failure. Select nursing measures to decrease cardiac workload. These include placing the patient in a semi-Fowler's position, spacing activity and rest periods, and providing a quiet environment. Carefully monitor drugs that increase the heart's and providing a quiet environment. Carefully monitor drugs that increase the heart's contractility and decrease preload, afterload, or both. Evaluate the effectiveness of your interventions on an ongoing basis. The patient may be anxious about the diagnosis of myocarditis. Assess the level of anxiety, take measures to decrease anxiety, and keep the therapeutic plan. The patient who receives immunosuppressive therapy is at risk for infection. Monitor for complications and provide the patient with proper infection control procedures. Although most patients recover spontaneously, some develop dilated cardiomyopathy. If severe heart failure occurs, the patient may need a heart transplant. There will be no test questions on rheumatic fever and rheumatic heart disease. But since rheumatic heart disease is very much like all the other inflammatory heart diseases, I felt it fit into our discussion. Rheumatic fever occurs as a complication 2 to 3 weeks after a group A Staphylococcus pharyngitis. Signs of rheumatic fever appear to be from an abnormal. Rheumatic fever affects the heart, skin, joints, and the central nervous system. Rheumatic heart disease caused by rheumatic fever primarily affects young adults. Rheumatic fever has declined in developing countries because of the effective use of antibiotics to treat staphylococcal infections. However, it is still an important public health problem in developing countries. Risk factors include age, gender, and environmental factors. About 50% of rheumatic fever episodes are rheumatic pancarditis, involving all layers of the heart: the epicardium, the myocardium, and the pericardium. Rheumatic infective endocarditis is found mainly in the erosion of the valve leaflets. Vegetation forms from deposits of fibrin and blood cells in the area of erosion. The lesions initially create thickening of the valve leaflets, fusion of the commissures and the chordae tendineae, and fibrosis of the papillary muscle. Valve leaflets may become calcified, resulting in stenosis. These less mobile valve leaflets may not close properly, resulting in regurgitation. The mitral and aortic valve are most often affected. Nodules, called Aschoff's bodies, are formed by a reaction to inflammation with swelling and destruction of collagen fibers. As the Aschoff bodies age, they become fibrinous, and scar tissue forms in the myocardium. Rheumatic pericarditis develops and affects both layers of the pericardium. The layers become thick and covered with a fibrinous exudate. A serous sanguineous pericardial effusion may develop. When healing occurs, fibrosis and adhesions develop that partially or completely destroy the pericardial sac. Damage to the heart begins during the first attack of rheumatic fever. Recurrent infections can cause structural damage. Carditis is the most important manifestation of rheumatic fever. It results in three signs. 1. A heart murmur or murmurs of mitral and aortic regurgitation or stenosis. 2. Heart enlargement and heart failure from myocarditis. And 3. Pericarditis resulting in muffled heart sounds, chest pain, and a pericardial friction rub or signs of effusion. It was probably mentioned in your adult class that the patients who have RF develop monoarthritis or polyarthritis. This happens in about 75% of the patients. The inflammatory process affects the synovial membranes of the joints. This causes swelling, heat, redness, tenderness, and limitation of motion. The larger joints, particularly the knees, ankles, elbows, and wrists, are most often affected. Sydenham's chorea is the major central nervous system manifestation. It is characterized by involuntary movements, especially of the face and limbs, muscle weakness, and speech and gait problems. Erythema marginatum lesions are a less common feature of RF. They only occur in about 10% of RF patients. The bright pink, non-pruritic, map-like macular lesions occur mainly on the trunk and proximal extremities. They intensify with heat. Subcutaneous nodules associated with severe carditis are small, hard, painless swellings found over extensor surfaces of joints, particularly the knees, wrists, and the elbows. So those are the major criteria, clinical manifestations that present in a patient with rheumatic fever present. But there are some minor clinical manifestations. In fact, there's a table in your book, 36.7, that can be helpful in diagnosing the disease. This is particularly helpful when there's only one major criteria present. In addition to the major and minor criteria, there must be evidence of a preceding group A streptococcal infection. There's a table of infection. In terms of cardiac issues, patients can develop chronic rheumatic carditis that results in changes to the valve structure months to years after an episode of rheumatic fever. Rheumatic infective endocarditis can result in fibrinous tissue growth in valve leaflets and chordae tendineae with scarring and contractures. The mitral valve is the most often involved. The aortic and the tricuspid valves may also be affected. This is another cardiac condition that results in the patients needing prophylactic antibiotics, similarly to endocarditis and pericarditis. These patients need to have their infective organ therapy. They will probably have to have several repeat sets of blood cultures done, and if the valve damage is significant, they may have to have valve replacement surgery. The nursing care is very similar to the patient with infective endocarditis. Most significant is, during the assessment, we want to try to identify when that pre-streptococcal infection occurred. Our nursing care is going to focus on relieving the manifestations from any of the systemic effects of rheumatic fever. So as we care for our patient's cardiac condition, we can't forget that they may develop neurological complications and musculoskeletal complications and musculoskeletal signs and symptoms, and we're going to be working with them to help relieve discomforts from all of those. Health promotion really focuses at early detection, so we want people to know that they need to report the signs and symptoms and get early treatment for streptococcal pharyngitis. Is at preventing a recurrence of the rheumatic fever. Prior history of rheumatic fever makes the patient more susceptible to a second attack after a streptococcal infection. The best prevention is treatment with prophylactic antibiotics. Patients with rheumatic fever without carditis need prophylaxis until age 20 and for a minimum of 5 years. Patients with rheumatic carditis and residual heart disease need lifelong prophylaxis. Most of the focus of the acute care is going to be to give those antibodies that's prescribed to treat the streptococcal infection. Teaching the patient to complete the full course of the antibiotics is vital to the success. Optimal rest to reduce cardiac workload and the body's metabolic needs. Position painful joints in proper alignment and apply heat for comfort. Give salicylates and NSAIDs and corticosteroids as prescribed for joint pain. After the acute symptoms subside, the patient without carditis can walk. The patient with carditis with heart failure may be restricted to bed rest. Stress the importance of gentle activities during recovery. As with all our other nursing care for all the other illnesses we've talked about, we want to evaluate to see how well we've met our expected outcomes. Can the patient perform their ADLs with minimum fatigue